Hello and welcome to your online lecture. This is going to be part 2 of drugs being used to treat inflammation. Today we're actually going to be discussing two kind of key groups of drugs, your corticosteroids and your counter irritants. Our first stop is really going to be to talk about the adrenal gland. Here is the anatomy, right? And so hopefully we all remember dissection and we remember identifying the kidneys. If not, here they are so beautifully. On top of the kidneys, or just superior to the kidneys, are our adrenal glands. We have a right adrenal gland and we have a left adrenal gland. And why am I talking about the adrenal glands? Because what we're talking about are corticosteroids, and naturally the adrenal gland actually produces two naturally circulating corticosteroids, and those are cortisol and aldosterone. Your cortisol is going to be what we call as a glucocorticoid. And then your aldosterone is going to be what we call as a mineralocorticoid. And the difference really is in their properties. Your glucocorticoids are going to be more responsible for kind of anti-inflammatory effects. Your mineralocorticoids are going to be responsible for kind of maintaining balance. And so as we look at the role of cortisol and aldosterone, keeping in mind that your cortisol is a glucocorticoid and your aldosterone is a mineralocorticoid, then keeping these things in mind, it becomes important to kind of think about the physiology. And so your cortisol is going to regulate your reaction to stress. Oftentimes when we're stressed, we might be down. So when we get like pumped or if we get excited in that fight or flight response, most often that's the release of cortisol triggering that. In addition to that, it regulates our metabolism. So, after we eat and food starts to break down or degrade, it's going to be regulating the metabolism. One of the things that free-floating cortisol does is it also actually suppresses inflammation. So we have this natural kind of anti-inflammatory kind of just inflammatory mediator kind of just sitting there in the bloodstream, right? Kind of regulating inflammation. It also is responsible for regulating blood pressure, increasing blood sugar when blood sugar drops. And then it does, when triggered in excess, it can decrease bone formation. So oftentimes when we have patients who maybe struggle a lot with like stress fractures, for example, one of the things that they start to look at when they start doing blood draws is what are their cortisol levels like, right? Is that one of the reasons we aren't seeing bone formation occurring, or we're starting to see repetitive stress fractures over time? On the opposite end of that, your aldosterone doesn't really have the inflammatory properties, but it does control blood pressure. It also is responsible for doing some of the mineral, kind of maintaining homeostasis for a lot of the minerals in the body, particularly the potassium and calcium pump. It's going to signal those kidneys to kind of absorb more sodium into the bloodstream, and then potassium into the urine. So kind of maintaining the balance between the amount of circulating calcium and potassium that we have. And then last but not least, it's going to help regulate blood pH, and in some ways kind of indirectly kind of help with gastric mucosa and gastric lining. So we can see two very different types of naturally circulating corticosteroids circulating. Really, though, the focus would probably be on cortisol because it has the ability to suppress inflammation. So would it surprise you that there have been drugs, corticosteroids, see that have been developed to mimic the role of cortisol, but maybe more in excess? So the goals of corticosteroid therapy then are really focused in on that suppressing feature of cortisol, right? And so we have derivatives of cortisol. And so we can see that here. One thing to note is that each of these drugs, even though they're going to fall more on the glucocortico spectrum, in other words, the anti-inflammatory suppressive spectrum, they also carry with them some type of mineral cortical properties such as balancing calcium and potassium, helping to regulate blood pressure, metabolism, etc. But here are some of the derivatives of cortisol. So what I'm going to try to do is show you just how uniquely and distinctly but very similar they are. So here is cortisol, which is our naturally circulating cortisol. And you can see here there are 1, 2, 3 OHs, and then you've got 2 oxygens, and you'll see some double bonds here and there, double bonds there. Now what I'm going to try to do is kind of highlight that for you in the different iterations. So we'll take let's go with corticosterone. So we've got 2 OHs instead of 3. You can see that we have 2 oxygens. right? So we can see the difference in makeup really varies in the the OHs, right? We can see that there. And then maybe we'll go with something that's probably more common to us, which is cortisone, not cortisol. We have 2 OHs. You can see those here in as opposed to 3. And then yet we have 3 free floating oxygens versus your 2. And then you can see obviously a double bond with both of those oxygens. So you can see the variations are just very subtle, but they are what make these iterations of cortisol more effective at or more potent at creating anti-inflammatory effects, right? But very small, subtle differences between the two. So what do we know about, because when we say corticosteroids, many people focus in on steroids and they automatically, for some reason, have some type of negative thought process, right? Your steroids and your corticosteroids are very lipid-soluble hormones, mainly derived from cholesterol, right? But the difference between an anabolic and a corticosteroid really are 2 things. Number one, the hormone that it's derived from or the anatomical structure, right? Your corticosteroids are going to be produced in the adrenal gland and released and controlled by the adrenal gland. Your anabolic steroids are very artificially made from testosterone, right? Our corticosteroids aren't necessarily used to enhance performance, but your anabolic steroids certainly are. And then most corticosteroids are natural. However, they can be synthetically manufactured as well. So there are key characteristic difference between the 2 types of steroids. The focus of today's lecture will be on corticosteroids. So in terms of mechanism of action, this is interesting, right? So let's go back to our previous lecture and the arachidonic acid pathway, right? In our previous lecture, we said that many of our non-selective and COX-2 non-steroidal anti-inflammatory drugs would do what? They would have an effect right here in the pathway, right? So that's for review. Now what we're saying is, where in the world do our corticosteroids actually have an impact, right? Where do you think they actually impact this process? Great. If you said in these words, they inhibit the activity of phospholipase, you would be correct. So they intervene right here. What does that mean? What's phospholipase do? Does anyone remember? They allow arachidonic acid to unbind from the membrane and then to branch out into its 2 key metabolites, right? COX and lipoxygenase. So when you think about a corticosteroid, it's going to impact this part, right? So phospholipase isn't produced and doesn't allow for the release of arachidonic acid, right? Which means then we don't have the 2 pathways or metabolites being created. And so it blocks higher up on the arachidonic acid pathway, right? And this can be good and it can be bad. It's going to reduce inflammation, right? Because you don't have your prostacyclin, your prostaglandin, and your thromboxanes or your leukotrienes being produced as rapidly. I'll say that, right? They're suppressed, which means ultimately there's decreased vascular permeability, right? Decreased chemotaxis, which can be negative, right? The other thing that we see is there's decrease in pain because we don't have prostaglandin synthesis and we don't have the bradykinin system being activated, right? So these things are all very, very, very great, right? So we'll decrease arachidonic acid cycle, decrease prosynthesis, and other inflammatory mediators. Examples, your histamines, your leukotrienes, your prostaglandins, and that's all great. That's all going to reduce inflammation and reduce pain. But remember, on that left side of that older chart, we talked a lot about phagocytic and non-phagocytic cells, right? And we said that our leukocytes are going to be important because we're going to have our macrophages and our neutrophils, right? They're going to come in and they're going to start cleaning up the area, right? Remember that? And then we had our platelets, right? And our lymphocytes that would then come in and start to wall things off. Well, we have a decrease in the migration of those items. So in addition to blocking all of the inflammatory response, we also reduce chemotaxis. We also reduce the number of cytokines that are being released, which means the macrophages and the neutrophils, they don't have direction and they might not get to the site like they're supposed to. And so healing may be delayed just a little bit. And so that's something to consider as we start thinking about systemic oral corticosteroids, particularly those that are going to be used to kind of treat maybe cancer, for example, maybe even some of the common colds that we can't kick with an antibiotic, for example. Those are things to consider. So as we think about the other two actions of corticosteroids. So if we go back, number one, their mechanism of action is right here in this particular portion. They're an inhibit phospholipase production, which inhibits the ability of arachidonic acid to unbind and then branch off into these metabolites, right? So as we move to the next slide, we've talked a lot about how it will inhibit phagocytic and non-phagocytic action. And as you think back to that inflammatory response lecture, one of the things that you know is that your fibroblast will start to lay down and they'll start to trigger collagen synthesis, right? And this is a key component and adverse effect of injectable corticosteroids is that they sometimes cause the inhibition of collagen synthesis, right? And this is hard because they can't be separated. In other words, we want all of the anti-inflammatory effects, but then with the anti-inflammatory effects come some of the degradative effects, the negative effects, the deleterious effects, which one of them is decreased collagen synthesis, right? So what that means is we don't have those fibroblasts laying down, which means new tissue is not laying down, which means we might have a delay in the actual healing process. Now, of course, at some point in time, that collagen synthesis will recover, but in those early formative days, in that proliferation phase, like day 6 or 7, we may not have the collagen that we need to really lay down that actual patch. So that's something to keep in mind, and it's one of the reasons that we see an increased risk for rupture with cortisone steroid injections in particular. And so the other thing that we consider is, remember, we talked about those kind of protein pathways. And this is really truly linked to number 2, which is we have an inhibition, right, of our fibroblast, a decrease in fibroblast proliferation, which then essentially leads to decrease in collagen synthesis, protein synthesis. And so we have a weaker tissue in the earlier phase of the proliferation. So it may, in essence, extend the proliferation phase of healing to be considered. Another thing about oral corticosteroids is that they are powerful immunosuppressants. So oftentimes in a cancerous state, for example, where we want to destroy all of the cancer, we will use corticosteroids as an immunosuppressant. In fact, when my dad had cancer, he took prednisone, right, which is an oral corticosteroid, and for good or bad, right? So the good was it destroyed all of the cancer. The bad is there were lots of adverse side effects because it suppresses so high on the arachidonic acid pathway, right? And we can think about all of the important effects. So let's go back to this slide here. Some of the effects of cortisol and aldosterone. Remember that controlling blood pressure, for example, balancing calcium and potassium, which really helps us retain water or get rid of water, right? All of those things we have to consider when a patient is actually taking oral corticosteroids. They can be great and they can also be negative because of how high they act on the arachidonic pathway. Now, in terms of corticosteroid drugs, let's talk specifically. Cortisol or hydrocortisone is naturally occurring, but we also have kind of that manufactured version of that. It can be oral, parental, or topical. Most often we'll see it orally and topically. Then you've just got cortisone, which can also be taken orally and topically. You've got prednisone, which is most common in cancer, maybe even systemic infections to reduce an inflammatory response. That's oral. Triamcinolone is oral. Dexamethasone is the corticosteroid that is most often used in cortisone injection. So most often we see that as injectable. But dexamethasone is an anti-inflammatory agent that can also be placed in phonophoresis, so ultrasound with medication. So it can also be topical. And then you've got fludrocortisone, which is another anti-inflammatory drug. So you can see most of the options are going to be injectable, topical, and or oral. Now, one thing that becomes important for you as athletic trainers is oftentimes as athletic training students, you might actually be asked to do the what's called a med draw, where you're actually pulling the corticosteroid out of its bottle in its fluid form. And so what are you pulling out? So for lidocaine, which is an analgesic, you'll take about 4 cc's. Marcaine, which is also an analgesic, you'll take 4. Dexamethasone, 1 cc. Depomedrol, you'll take 1 cc, or methylprednisolone, you'll take 1 cc. And so you'll see your physician will say, hey, go ahead and get a 21 gauge needle, go ahead and fill it with 4 cc's of Marcaine, and you'll actually be asked to do that, right? Now, the onset of effect, look at this, right? Because for the most part, you're injecting, it's going directly into the site, 0 to 10 minutes, up to 30 minutes, rapid onset, right? And the duration of the effect can be relatively long. The ideal would be if we have a direct area that can be injected, then to avoid this systemic effect of the oral corticosteroids, because they have such a systemic effect and because they interact so high on that arachidonic acid pathway, right? So joint-specific injections, we're looking from shoulder all the way down to ankle. Your needle length is going to depend on the joint that you are actually inserting, right? The smaller the joint, the shorter the needle. The deeper the joint, the longer the needle. And then in terms of gauge, it's all about how much skin you're actually going through, right? So 21 gauge versus a 23 or 25 gauge, right? And so your physician will expect you all to know this as you're working with them in the clinical setting. So in terms of corticosteroids, what are the indications? When do we use them? How do we use them, right? That's really the role of today's lecture. When they're administered systemically, so orally, they can affect all parts of the body, right? And they're going to do that because remember, we have phospholipase here, right? Phospholipase, I think that's right. Okay, you have phospholipase, you have arachidonic acid, and then you have your COX, and you have your lipooxygenase, right? And so it's interacting right here, right? We can see that. Most corticosteroid drugs are prescription only. The only one that is really over the counter is hydrocortisone, and that's in that topical. In the topical form, right? You're going to rub that over an area that might be itching, right? Have inflammation, like a rash, for example, some type of athlete's foot, jock itch, ringworm, all of the things that we already talked about, right? To reduce itching in that particular area. And then most corticosteroids are typically, at least in the field of athletic training, going to be prescribed for our itises. That's what I call them: arthritis, bursitis, tendonitis, tenosynovitis. Most definitely an oral or topical can be prescribed for skin disorders, psoriasis and eczema, and then nasal inflammation and allergic rhinitis. And then we'll talk about asthma in its own online lecture. So you can see that there is an array of different reasons that we use corticosteroids. They most often get notability for injection, but we certainly can take them orally. And in fact, we'll encounter patients who are ill who actually do take them orally and have major systemic adverse side effects, right? So in terms of indications for use in sports medicine, inflamed joints that are unresponsive to NSAIDs. So you give a patient an NSAID for, let's say, 7 to 10 days, swelling isn't going down, then your physician might decide, okay, let's go with something either orally or let's directly inject into that particular joint, right? Or maybe a patient has an allergic condition to maybe the oral medication that they've been prescribed. So in terms of pharmacokinetics, it's lipid soluble, right? Which is great. That means it's stored by the body. It's going to be absorbed quickly. More than likely, it's going to have long-lasting effects depending on the actual target tissue. There's corticosteroid injection therapy. I can think about 2 different areas. Obviously, the knee would be an example, and the spine is another example. But the key thing that we have to consider, and I know you all have heard this, like no more than 3 cortisone injections in 1 year, is because it blocks way high on that pathway, right? It's going to reduce or inhibit the phagocytic and non-phagocytic structures, physiological structures, right? And so because of that, it's been linked to inhibition of collagen synthesis because you delay fibroblast proliferation, which means you delay the laying down of new, strong, healthy tissue, right? And because of that, it delays tissue healing and increases the risk for tendinous injury, because the tendon's going to be a lot weaker than it would be as if we didn't either orally take that corticosteroid or inject it specifically into that joint. So some routes of administration are oral inhalation. So we're going to spend a whole bunch of time on this, but all of our asthma medications will have maybe some sort of corticosteroid. Nasal inhalation, we see this a lot where you get the over-the-counter nasal sprays, which would reduce maybe some of the hay fever signs and symptoms. Injection is going to be most common, at least in the field of athletic training. The most common drug that we see in cortisone injection is going to be dexamethasone. It's intermediate, meaning about 30 minutes to have an onset of action, but it can be used intramuscularly and intra-articularly. If you're thinking more about bursa and tendons, the bentamethasone tends to be more forgiving on the tendons, and so that tends to be the drug of choice. And then you have oral, right? Prednisone is probably the most common oral corticosteroid that we've seen, most often used to treat systemic diseases. So your gouts, your arthritis, your fibromyalgia, for example. And then we have topical, at least over the counter, you have your hydrocortisone. You can also get that in prescription base too. In terms of systemic and adverse side effects, the most serious systemic effect would be hyperglycemia. And why is that, right? If we were to go back to this slide, why would we say hyperglycemia? Tell me one reason. Great, because we know that cortisol does what? It increases blood sugar, right? So if we were to go back to the slide that we were on and kind of really think through that, anytime we inject more cortisol into the body and we have naturally circulating cortisol, then we might have a situation where we create a hyperglycemic patient. So we have to be very, very, very careful. There's increased risk for gastrointestinal ulceration, especially if the oral medication is combined with alcohol and or NSAIDs. So in terms of local, it just depends. If it's an injection, they might have pain in the injection site, right? They might get a rash from the injection or some type of itching. They might even get an infection because there's open skin. If it's oral, they might suffer from some type of GI pathology. Well, the research has suggested that corticosteroids actually cause restlessness, almost like a caffeine-like state. And then with diabetics, we just want to be careful, particularly with the cortisol, because it will increase the blood sugar levels. Now, we have two different types of diseases of the adrenal gland, of which we should be concerned about, particularly as it relates to the oral corticosteroids that a patient might be taking over time. These two diseases are kind of caused by extreme ends of the spectrum. So your Cushing's disease is a collection of signs and symptoms that really are caused by prolonged exposure to corticosteroids, right? So a patient takes it too long. As such, essentially, you just have a high level of circulating cortisol. And so you have a patient who has uncontrollable high blood pressure. You might start to see the retention of water. So like particularly abdominal obesity, maybe in the hands, right? Because you're not able to control maybe the mineral balance, for example. So you need to have that patient really stop taking the medication and try to get the cortisol levels under control. Then Addison's disease is going to be the complete opposite, right, y'all? Addison's disease itself is most often associated with some sort of tumor, most often, or damage to the adrenal cortex, right? And so what happens is the adrenal gland typically won't produce enough of the hormone. So you might not have enough of the cortisol circulating or enough of the aldosterone circulating, right? But this isn't most often caused by drug use, but certainly impacts the amount of circulating corticosteroids, natural corticosteroids circulating and available. So potential adverse reaction, you can have adrenal suppression, the development of hypertension, right? Because aldosterone and cortisol are going to control your blood pressure. the development of osteoporosis, particularly in women that are more susceptible to that, increased susceptibility for infection because oral corticosteroids are immunosuppressors, right? So your immune system has the inability to fight off some of the diseases that it normally would have been able to. You might have some muscle pathology, particularly with corticosteroid injections. Remember, cortisol, it controls blood sugar levels. And so if you have increased levels of cortisol circulating, you're going to have an increase in blood glucose levels. So we have to be careful as we think about these drugs, especially the oral types. Now, there are different ways in which corticosteroids can be administered, and that is probably important for y'all to at least understand that. So you have oral inhalation, nasal inhalation, I think I said this already, intra-articulation, bursa injection, tendon injection, right? Oftentimes, if we are doing a draining as well, you'll still inject with a corticosteroid to reduce the pain and reduce the inflammation associated with the removal of fluid from a particular area, right? All of these to say is it's important to know the different ways in which corticosteroids can be administered. I would say the two most common ways that we see corticosteroids administered would be oral to treat a systemic infection or pathology, and then in injections, right? At least in the field of athletic training. So as we consider when we should be using corticosteroids, we really want to consider whether or not we want it to be a direct treatment approach, an injection, or a systemic administration, keeping in mind that systemic administration has deleterious effects because of how high on the arachidonic pathway it's going to impact, right? And then its chronic use can lead to serious side effects, Addison's, Cushing's disease, for example. So we just have to be truly careful with that, right? Your injections may produce adverse side effects. So example would be pain in the joint, tissue atrophy from repeated injections, right? The risk for infection increases because we're piercing the skin. And then just keep in mind, anytime we take the oral corticosteroids, our immune system's suppressed. So this patient's more susceptible to colds, for example. So as you think about travel with a patient who's on corticosteroids, maybe they wear a mask to avoid getting a viral infection most often. 6, your corticosteroids can mask an infection, right? So you want to be careful of patients who maybe have weakened immune systems. Avoid corticosteroids with the following patients: AIDS patients, heart patients, diabetic patients, for all of the reasons of cortisol and aldosterone controlling many of these processes, right? Your liver and your kidney, TB, lupus, these are all infections which might make the patient more susceptible to a supra infection is what I would call it, right? Prolonged use may also cause some of the things that we already talked about. Osteoporosis, for example, may make them immunosuppressant and more at risk for development of viral and bacterial issues. And then osteonecrosis. The big thing is bone tissue degradation, right? And that's a big concern. So these substances are currently not banned by the NCAA, but are banned by the USOC as it relates to any intravenous, intramuscular, rectal, or oral. So if a patient is on an oral medication or needs to be injected, then you would need to have a physician sign the WISE for that. Intra-articular injections, just what does the literature say about that? For osteoarthritis patients, intra-articular injections tend to be less effective and short-lived. In fact, you probably want oral, right? So it's more systemic, since this is a systemic, can be systemic, right? So we really want to treat this probably with an oral medication, right? Rheumatoid arthritis, most often intra-articular injections are going to work 50% of the time. Again, if it were me, I'd probably consider an oral corticosteroid form of treatment for these patients. For tenosynovitis and bursitis, the research is very, very clear that in our itises, our plantar fasciitis, our tennis elbow, they respond relatively well. That we should avoid certain areas, right? Y'all know this. What are the areas we're going to avoid? Our patella and our Achilles tendon, right? Number one, they already have a lack of blood flow. So then to inject directly into that area and reduce the risk of fibroblasts laying down, and then an area that lacks blood flow, you're at ripe and ready for a tendinous rupture. So just be careful, right? Your bursitis tend to respond relatively well to injection, so that would be a consideration. And then trigger finger, which you won't see in the athletic population, but certainly if you're moving out of the field of athletic training, you could certainly see patients who respond well to that. Crystal-induced osteoarthritis so these injections are effective in patients with gout, but again, I would go systemic and probably do oral. Entrapment neuropathy, such as carpal tunnel, they respond well, but what we see is skin color changes in those patients because it's so superficial, so just be careful. So for athletic trainers, what are we going to do? You advise asthmatic patients to take corticosteroid inhaler before exercise. It can be very helpful in the process. Again, we're going to talk about this a little bit more when we get to the asthma chapter. Don't stress the joint too soon after an intra-articular injection. The reason for that, you all know now. You all can tell me that our fibroblast production is slowed down or delayed, and so there isn't as strong of tissue, so we're at a risk for the development of ruptures, right? Any athlete taking or receiving injections of corticosteroids should certainly be under the care of a physician. The only exception would be a over-the-counter hydrocortisone cream. If you have a patient who's diabetic, then you want to work in conjunction, interdisciplinary approach to figure out how we maintain a steady blood sugar level, right? Okay, systemic corticosteroids increase the risk of GI ulceration because much of that's going to be absorbed in the GI tract, especially when they're combined with NSAIDs, right? And then in general, I've said this 100 times, it inhibits collagen synthesis, so we want to be careful with our corticosteroids. All in all, before I move into counter irritants, your corticosteroids are such a unique approach to treating inflammation. From a direct standpoint and treatment approach, corticosteroid injections can be great if we use them appropriately and if we understand the risk to the patient. Your oral corticosteroids are powerful anti-inflammatory agents, which certainly have deleterious effects, and we've seen can increase blood pressure, impact the kidneys. But certainly if our over-the-counter or our traditional prescriptive NSAIDs aren't working, then corticosteroids might be the next best adjunct therapy to reducing inflammation in a patient with chronic inflammatory responses. Now we move into something a little bit more fun, our counter irritants, aka our topical anti-inflammatory products. You all might know them as things like Icy Hot, Tiger Balm, Bengay, right? These items are always applied topically to a specific area. The goal is to kind of loosen the area and then reduce the amount of pain in the area, right? So this is a very superficial approach, a very superficial direct approach to treating inflammation in a local area. Now I want to say this with a caveat, the local area should not be an open injury, right? I would assume you would know that. Counter irritants are most often over the counter. However, there are some counter irritants that can be prescriptive, specifically if they're mixed with an analgesic product or a drug. So let's move forward. Interestingly, I wish I had the answer to everything, but this is one area where the exact mechanism is unclear. So I'm going to make some Cosby guesstimations here. What we know about counter irritants is either when you put them on, they either cause a cool, like you could blow on it and feel the wind, or a very warm, itchy kind of burning sensation, right? And so they stimulate these sensations, hot, cold, itching. What I think happens, and you're going to learn this in the first week of your modalities class, is the stimulation of the gate control theory of pain, where there is a rubbing mechanism, which then stimulates the A beta fibers, to travel to the brain and reduce the pain sensation. So it's an indirect way to block pain going to the brain. It can also, they say, reduce the circulating level of substance P, which is also a nociceptor trigger like your bradykinin or your prostaglandin. So these are kind of predicted ways in which rubbing a counter irritant on the skin reduces pain in your particular patient, right? Now, that feeling of warmth or cooling may give the athlete confidence that the drug is working. So there is something to be said kind of about that placebo effect of applying that counter irritant, right? Now, side effects, Love it. Toxicity is minimal. We're not going to get the GI irritation that we've been talking about with the corticosteroids or the NSAIDs, whether they're COX-2 or non-specific NSAIDs, right? The most common things that we see: rashes, hive, maybe even skin burns or eruption if the students are applying too much of it too soon, too fast, right? And then the FDA considers external analgesics safe for use by adults. So you can use this as much as you possibly want to. There really aren't very many adverse side effects. What do we want to do as athletic trainers for our student athletes? Number one, make sure they aren't allergic to any like local anesthetics or aspirin if in fact the counter irritant is laced with, let's say, an aspirin, right? Topical painkillers are not currently banned for use before competition, so rub as much as you want. However, the long-term use should be discouraged, and that's because there's an increased risk for the development of skin ruptures, increased risk for infection. Otherwise, there isn't really any adverse effect. You want to avoid vigorous massage after the application of topical anesthetic, particularly on the next slide. I think I talk about the ones that cause kind of the burning sensation. Particularly those that cause a burning sensation. And apparently I don't have the slide in here, so I'm going to go back 2 or 3 slides and talk through this a little bit more. So your menthols, they're going to make it feel really, really cool, if that makes sense. And then anything that has a capsaicin in it is going to make it feel like burning. And capsaicin is actually made with red chili peppers, and so that's like Tiger Balm would be an example of a structure or a counter irritant that has the capsaicin in it. But your menthols, your methylsalicylates, those are all going to make you feel really cool. So you have to pick and choose which one works best for you. You may find that one that has menthol doesn't work. You can also see that some of these are mixed, right? You'll have maybe capsaicin, you'll have camphor, which also makes you feel cool, and then you'll have some type of NSAID also in that process. So you have to pick and choose which one works best for you and for the patient. In terms of guidelines for athletic trainers, the last one is just making sure you're aware of the skin infections that could occur, right? So if you have an open wound, you should not rub that on, making sure your patient's hands are clean before they start rubbing the counter irritant on. All in all, I used to not be a fan of counter irritants, but I love the placebo effect. Hey, what does rubbing something on the skin and making it smell like peppermint do? The other thing that I think about our textbook is it's a little outdated because we have these things called essential oils, which also could have some of these kind of properties, right? Like that menthol effect, the cooling effect. Peppermint essential oil has been linked to anti-inflammatory properties too. So thinking about how do we start integrating the use of essential oils in the treatment of, let's say, inflammatory or analgesic or painful impulses will be extremely important. And that's all I have for you. I wanted to end by saying this and kind of putting it all together, right? Because we talked about NSAIDs, we talked about corticosteroids, and they had their own lectures. And the reality is both NSAIDs and corticosteroids work to reduce inflammation in the body. And they do that drastically different, right? Your NSAIDs are going to block COX, right? And then your corticosteroids, phospholipase, right? And so they do that in different ways, but the moral of the story is they do it, right? Your corticosteroids are going to have more systemic effects, especially those that are taken orally, right? Your NSAIDs are going to be more readily available to you over the counter. And so it's the NSAIDs that are really important to us as athletic trainers, right? Most are available over the counter, but certainly there are prescription doses. All of the ones that we discussed were orally available. And then you could see they're going to have multiple effects. They're going to reduce inflammation, reduce pain, reduce fever. And in some cases, they might become anticoagulants, particularly your aspirin, right? Which continues to bind or has a permanent bind to that particular platelet, right? Some other differences really are in the side effects. We know that our traditional NSAIDs are going to cause massive gastric irritation, specifically those that are non-specific, right? Because they're going to limit or reduce COX-1, and COX-1's major role is to line the mucosa, right? And so we'll see gastric irritation in the development of peptic ulcers. So it becomes extremely important to consider that. On the other end of the spectrum, when we think about corticosteroids, if we suppress our adrenal gland, we can oftentimes see the development of Addison's disease or Cushing's disease, right? And so that becomes a concern. If we have too much cortisol, then we can see an increase in blood glucose. And so that becomes a concern for a diabetic patient. And then the big thing that we're really concerned about as clinicians, particularly as it relates to corticosteroid injections, really has to do with this concept of increased risk for injury to the tendon because our fibroblasts just are not stimulated to form because our phagocytic and non-phagocytic cells are being inhibited, right? And so we can see all of these things, and we can say that there are physiological differences in the way that these two drug categories work, but certainly our NSAIDs are something that we're going to covet. We're going to own those doses because it becomes important since we're able to administer those. And so that's all I have for you in this online lecture. Truly do hope you learned a lot about NSAIDs and corticosteroids and the pathways in which they regulate.